and my dear students and staff, it's my privilege to welcome you all on this auspicious Foundation Day ceremony of our Department of Pediatrics. I would request our respected Professor Shelly Avasti ma'am, the head of our department, to kindly highlight the essence of our foundation.
Thank you, Dr. Arisha. I welcome Dr. Harish Chelani to Department of Pediatrics. I welcome all of you online, and I would like to thank Dr. Suren Verma, who has agreed to give the oration, Dr. N.L. Sharma oration today. As you all know, the department foundation stone was put in 1954. Perhaps we are one of the first departments or second department in the country which started pediatrics as a separate branch. Starting with 20 beds, now we are 280 beds. Dr. N.L. Sharma was the first head of Department of Pediatrics. There are many illustrious alumni who are his students. Dr. Suren Verma is one of them. So indeed, it's a pleasure to have Dr. Verma today. The second oration is Professor P.K. Mishra oration, which will follow Dr. N.L. Sharma oration. And we have Professor Chelani to deliver the Dr. P.K. Mishra oration. I now request Dr. Nishant Verma to please carry forward the oration proceedings so that we can have the oration begin now. डीसी सर को लिंक चाहिए यार प्रोग्राम का चलो तुम बोलना शुरू करो लिंक किसके पास तुम हमें भेज दो
A very good morning to all of you. I welcome you all on behalf of Department of Pediatrics to the Foundation Day ceremony of our department. First, we will be having Professor N.L. Sharma oration. The late Professor N.L. Sharma was the founder head of Pediatrics Department, KGMC. He joined the department as a faculty in the Department of Medicine in KGMC, then it was the Medical College. He was a great visionary and mentor to many pediatricians. His family instituted this oration in his memory. So this year, this oration is being given by an illustrious alumni of our department, Professor Suren Verma. He's a graduate and postgraduate of KGMC, and after doing his MD in pediatrics from KGMC, he went on to US and did 1-year fellowship from Boston, and then worked at prestigious institutes like Harvard and at MIT. In 1974, he moved to Texas Tech University, where he established the pediatric residency program and also established the pediatric endocrinology division there. He was instrumental in getting a law passed for screening for congenital hypothyroidism in Texas. Currently, he is a university distinguished professor at Ted Hartman Endowed Chair in Medical Education at Texas Tech. He serves as Executive Associate Dean for Graduate Medical Education and Residence Affairs at Texas Tech University of Health Sciences, where he oversees all the residency and fellowship program there. He's a Grover E. Murray Professor at Texas Tech University Health Science Center. So we welcome Professor Suren Verma. He will be joining us online and will be delivering his oration on a very relevant topic about ethical issues in pediatric endocrinology. Thank you.
Being an investor myself for the last 8 years, what I have realized is people don't invest in the stock market for 3 reasons. Reason
तो भाई क्या है ना यहाँ हम केवल न्यूज़ पढ़ा देते
most likely not medical university. Good afternoon or good evening, whatever time you have. This is Surendra Verma. I am very honored to be giving this oration named after Professor N.L. Sharma, who was my mentor and a great influence on my career. I dedicated this oration to my teachers and friends at King George's Medical University. I have no conflict of interest in the presentation of this topic. Anytime ethical issues we talk about, I have selected 4 for the sake of time issues: disabled child, prescribing growth hormone, transgender medicine, and disorders of sexual dysfunction. The 4 pillars of ethics are beneficence, non-maleficence, anatomy, and distributive justice. Now, regarding endocrine care of disabled children, example is Ashley is a 6-year-old with cognitive delay and neurologic and physical disabilities. She presents to your office with her parents who report concerns for early puberty and tall stature. The family has seen an endocrinologist who has discussed the use of estrogen treatment for bone age advancement. This is a 7-month-old girl who was treated with high dose of estrogen and removal of breast tissue and uterus given increased cancer risk with estrogen exposure. After treatment, she was 133 centimeters with a predicted height of 165 centimeters. Parents had requested treatment given fear that increasing growth would make her care more difficult and require out-of-home care. Second, the given concerns they had that puberty would increase, risk for sexual abuse, discomfort of menstruation, difficulties with care with breast enlargement, and increase in size. Questions are, will such treatment work? Is halting this normal process of puberty justified given the concerns for daily living? Could this treatment be misused? Does the proposed treatment do justice to the scope of problems? The 4 pillars of ethics, beneficence, how does this intervention help the patient? It's difficult to predict height in these patients due to nutrition, scoliosis, and contraction. And what are the benefits to the patients? Are the benefits of such treatment for Ashley or those for the caregivers? It's hard to say. Probably it is more to the caregivers than Ashley. For other patients, do we think of the caregiver's benefit instead of focusing on the patient's benefit? Most likely not. Non-maleficence. Is there harm being done to Ashley with growth attenuation therapy? Especially need to consider if she can express harm or benefit from treatment. Is there harm in halting physical development? Is weight also a concern? Would you consider calorie restriction? In Ashley's case, surgical care may also be considered a harm. Autonomy. How can we consider Ashley as an autonomous individual? Is it more important with a child with disability to think of the whole family? Could her neurological status change with time? American College of OBGYN position paper is that sterilization of women is not appropriate, and given that hysterectomy is a major surgery, it should not be primary treatment for stopping the menstruation. Justice. Given risk for disabled individuals to be harmed, extra protection of their rights may be necessary. It should avoid slippery slope of using more severe treatments or increased off-label use of treatments. If society has made care of these patients difficult, should society also alter change to help with quality of life? Other scenarios. What about the use of estrogen treatment in tall girls? Until the mid-70s or so, the tall girls were being brought by their mothers that they did not want their daughters to be as tall as they, and they wanted them to have a better compromise height. We used to treat them with estrogen. Then we realized two things. One, is it ethically correct? Second, is it also, I think, side effects of estrogen? What if parents came with concerns about non-disabled child with what they perceive as a disability? How about removal of gonads to prevent entering puberty? What therapy would provide for parents that are concerned about their child with disabilities? Menstrual concerns, concerns about sexual development, possible sexual abuse. And what if there was an opposite case? A child with disability that is found to be growth hormone deficient. How would one respond if family were not interested in treatment? Would you recommend treatment? I think that the question is what benefit we are going to do with giving the increasing the height. Second, that if we did treat and this patient became very tall and unmanageable, it is more burden on the parents and society. And unless this child with disability was found to be growth hormone deficient and had hypoglycemic episodes. So if I say that there is a right or wrong answer for everyone, it is not a textbook answer. Each individual has to be treated differently considering the family circumstances, parents, and the persons who should help. Other one are the psychologists, psychiatrists, and social workers. So this is the first case which we talk about sexual dysfunction and how we do that. Now, ethical issues of prescribing growth hormone. As you know, that now with the synthetic growth hormone available, I think it is available for growth hormone treatment, particularly if they have growth hormone deficiency. However, it could be an abuse that many parents may push or press that regardless of growth hormone deficiency or not, they would like their child to be tall and be treated with growth hormone. Here, birth history, 38 weeks, vaginal delivery, 7 pounds and 21 inches long. Growth history has been on the short side, growing at the 25th percentile, but slowly over the last 2 years, declining to 3 to 5%. family history. Father is 5 feet 10 inches, mother is 5 feet. Mid parental height, which is father's height plus mother's height plus 5 inches divided by 2 for the boys. And for father's height plus mother's height, subtract 5 inches divided by 2 for girls. That is here, mid parental height is 5 feet 7.5 inches with a standard deviation of 3 inches. This is the weight, and this is the deceleration of the growth. You can look at this going below a third percentile. Normal growth rate is 5 centimeter per year in the pre-pubertal children between age 3 to 12, and onwards it would be, puberty would be different. So here 3 to 5 centimeters or 2 inches a year. If it is less than that, it is abnormal. This one had a prior evaluation. Normal IGF-1 of 210, which is normal. IgA binding protein of 3, that is normal. Normal thyroid function test, CBC, comprehensive metabolic panel, and have negative celiac screen. At 13, he has 10 2 pubic hair and 3 to 4 ml testis, which is early tertiary stage 2. His bone age here at age 13 is 12 years. With this, his predicted height, adult height is 62 inches plus minus 2 inches. As we have to do the growth hormone stimulation test most of the time, different, sometimes arginine and insulin, sometimes arginine clonidine, and here he has peak of 15.2 nanogram per ml, whereas normal is about 10. So here he has normal growth hormone secretion. Now, family is anxious to know if we can start growth hormone, as they are very concerned about his height. They have heard growth hormone can be used to improve final height in the diagnosis of idiopathic short stature if it is less than 2 standard deviation below normal. One can systematically review the ethical dilemma in this case and other cases, forming a framework for ethical decision making. The traditional players of ethics are beneficence, do good, non-maleficence, do no harm, autonomy, freedom of will, and justice. Now, does giving growth hormone to normal children conform to the norms of good ethical clinical practice? I would say, in my personal opinion, it is not. Because by giving growth hormone 1, we do not know the adult outcome, because by giving growth hormone, we may be advancing the bone age. And second, by giving growth hormone, are we saying that short is not good? There are many short people in the world who have done very well, and height doesn't make any impact on them. How a child is impacted about his teacher? Is this assessed and interpreted? Now, will intervention improve the patient's view of himself and prevent other psychopathology? Are taller children happier than smaller stature children? Are there long-term psychological consequences of short stature? In New York Times, in 1992, there was an article which said politics of height. And that reporter had investigated and found out that most of the time, taller men won the presidential election. Her title was Politics of Height. The shortest president in the US history is James Madison, who was 5 feet plus minus 2 inches. The tallest one was Abraham Lincoln. Lately, at that time, when she showed that in 1992, there were the senior Bush, Clinton, and Ross Perot were 3 candidates, and Clinton was the tallest one. Same time, it happened in 96 also, when I think Dole was the other candidate against Clinton. However, lately it has not become like second Mr. Junior Bush. When he was elected, he was shorter than Al Gore. Then next time, I think, of course, Obama is taller than John McCain. And then it is difficult to assess between President Trump and Hillary Clinton because different sex. So it is very hard to say. But if you look worldwide, China, many of the dictators there are above closely to 5 feet or so. And in my opinion, stature has not affected us in Indian elections. I may be wrong. How about anxiety over short stature have long-term effects? I think there's a short-term syndrome. You have heard about Napoleon complex. The people who are short, they have always worried about about height. However, psychosocial stressors associated with short stature, teasing and juvenilization, and degree of short stature. The problem is that bullying and teasing could be for other reasons also. If somebody is not short, somebody looks different. And stress from short stature and psychopathology, unless final height is short enough to actually be considered a disability, just like in Turner syndrome. There's a Before Sarah, he had a affirmed male gender identity and goes by the name Scott. Since age 3 or 4, Scott has felt more male than female. His parents thought he was a tomboy and that he would outgrow this phase. Over time, Scott has been able to clearly and articulately express his desire to be male. This has been consistent, persistent, and insistent since around age 12. On the advice of Scott's psychologist, he made a social transition at age 12, giving full time at home and the school as a boy. The school, family, and community have been supportive and accommodating. This has led to improvement in the school performance and depression initially. However, in the past year, Scott has been more socially withdrawn and depressed. He started arm-cutting behavior 4 months back. He is especially distressed about his breast development, which started about 2 years ago, and has been wearing tight breast binders and the baggy sweatshirts at home and school. He is extremely concerned about the prospect of menstruating, which has not happened yet. Scott and his parents are interested in starting pubertal suppression therapy and treatment with testosterone. Why do you think that symptoms increased at the start of puberty? Because worry became more. Do you think that Scott's transgender identity is likely to persist or resolve? What sort of evaluation, if any, would you like to perform? What are the ethical concerns regarding initiation of puberty suppression? What are the ethical concerns regarding initiation of testosterone therapy? So after an assessment by a psychologist who were expert in gender, the psychologist confirmed that Scott has gender dysphoria as outlined by the DSM-5 and co-occurring depression. It was felt that depression is related directly to gender dysphoria and the unwanted body changes associated with female puberty. Psychologists recommended treatment with pubertal suppression, followed by consideration of testosterone therapy if desire to transition persists. The recommendation is based on the Endocrine Society's guidelines and the World Professional Association of Transgender Health standard of care. Pubertal suppression is used to minimize gender dysphoria and halt unwanted pubertal changes. It is considered by many to be a reversible intervention which offers time for an adolescent to mature emotionally before considering irreversible intervention such as testosterone and surgeries. The suppression of puberty counterproductively interfere with the ability to mature emotionally. Pubertal suppression may have risks such as impaired bone mineral density, actual impact on adult height. Do the benefits of therapy outweigh the risk? What endpoints should be followed to monitor efficacy of treatment? What factors would you use to determine readiness for cross-section hormone treatment in a patient on pubertal suppression? So Scott, before that I go, I think here one thing that which is missing is that Scott talked to his classmates and explained that why it is this like this. And believe me, all of them very supportive of Scott. So now Scott is treated with a GnRH agonist, Histrelin. The medication was not covered by insurance. It's pretty big amount, and therefore the parents paid a very large sum for the medication out of pocket. They state that they made the investment because they felt it would help Scott live a happy and well-adjusted life. I commend the parents for their understanding. However, if the parents were divorced, only one of them was in favor, do you proceed? No, till both of them agree. Now, he was treated with Histrelin for 2 years. At age 16, he asked to start testosterone. He says, all the other boys have started puberty years ago. I can not wait anymore. He also desires a masculinizing chest surgery to remove the breast tissue already present. What are the ethical issues surrounding treatment with cross-sex hormones? Is there a certain age or level of maturity required to make a decision to start irreversible treatment such as cross-sex hormones? At what age can someone make a meaningful assessment or consent to start a treatment that may interfere with their future fertility? Should the endocrinologist suggest banking of ova or sperm prior to treatment? Should Scott, his parents are both, sign a consent form prior to starting testosterone? Would you refer Scott to a plastic surgeon to consider chest surgery? Because once you remove it, it is. I think it's a $1 million question, or there may be not a right answer. Now, consider 4 pillars of medical ethics in discussing the issue in a transgender patient: autonomy, beneficence, non-maleficence, justice. I think, therefore, guidelines suggest allowing adolescents to make a very adult decision prior to the age of consent, that is 18. Is essential for cross-sex hormone therapy for purposes of gender transition different from assessment for other medical treatment, such as treatment for cancer or surgery? There is evolving evidence there is a high rate of transgender in children with autistic problems. These patients may meet criteria for gender dysphoria but have limited means of providing meaningful consent. Can patients with more limited consenting abilities be treated according to the protocol outlined by the World Association of Transgender Health as well as Endocrine Society? Care guidelines suggest treatment with GnRH agonists and cross-sex hormones because it is thought to be the best interest of the transgender child to optimize mental health and physical outcomes. If parents refuse to support an adolescent who wishes to transition, is this an acceptable parental decision or a form of medical neglect? If they do so, that increases the suicidal tendency of the child. Is the patient's physician's role to convince parents to pursue treatment for their child or simply offer treatment as one of many legitimate options? Would your response be what would be your response if your medical center instructs you as a physician that you're not allowed to provide hormonal treatment for transgender adolescents? Many states in the United States are in that category, and I do not know how to deal with that. Despite the clinical practice guideline, there is no uniform agreement among pediatric endocrinologists that treatment of transgender adolescents is the correct approach. Without more long-term outcome data, thus providing irreversible treatment to transgender adolescents, violate the principle of non-maleficence. Alternatively, thus withholding treatment violates this principle. Justice insurance companies do not provide coverage for GnRH for such conditions. Treatment with medication not covered by insurance provide barrier to families with limited means. It creates a socioeconomic injustice for some transgender children. In what other ways can you apply the justice pillar to transgender health? I do not know, in India, have you seen, I saw on Netflix an Indian movie called Chandigarh Ashiki. They are talking about transgender. So at least awareness is there, and hopefully we all make a justified decision in the benefit of the child and family. Last segment is ethical issues in children with disorders of sexual development. One day you are called about a 7-week-old male whose neonatal screen for 21 hydroxylase deficiency shows positive for congenital adrenal hyperplasia, that is CAH. Pediatrician calls you by phone, a little boy who was seen in the office the previous day because of weight loss and jaundice. There was no phototherapy or
physical therapy today or physical
today. And the child was sent home with plan to continue breastfeeding with formula supplementation and repeat weight check-in 2 days. You meet the family in the emergency department, where you can learn that there are 3 other sons, and the family is originally from Eastern Europe, and they have never heard of CAH. They have named their child Nate. You are careful not to refer to the child's gender. What are steps as a pediatric endocrinologist? What issues do you anticipate facing as you prepare to mate with this family? After assessment the baby and determining that your signs of moderate dehydration and high bilirubin, you order appropriate lab. You gently begin to explain to the parents what CAH means. Drawing from them the adrenal steroid biosynthetic pathway, and where you're quite certain the problem is for their child. Would you introduce the issue of gender at this point? If so, the way I would say, I would caution them that it could be not made, it could be a female. And this is why I think that I would at least broach the topic so that it is in the back of your mind. Reveals severe virilization with a phallic structure, fused labial scrotal folds, and very mild hypospadias. No testes are palpated. That night, you obtain a pelvic ultrasound, which demonstrates internal female genitalia, uterus and ovaries, whereas he was raised up to laudanum as a boy. Karyotype takes few days, so it was not bad. The parents are very resistant to the idea that Nate is not a boy. How one should approach the discussion of these results with parents? What options do the parents have when deciding the gender of rearing? Now, child is medically stabilized on a steroid. Chromosomes show 46XX. Parents say they will never tell their child about the ambiguous genitalia and will proceed with urological surgery at the earliest opportunity prior to 6 months. As a matter of fact, it has been proven that after 15 to 18 months, permanent imprinting takes place. Now there is a debate whether this permanent imprinting takes place in utero. They agreed to raise the child as a girl and rename her Sarah. They also decide against disclosing the diagnosis to their extended family, as they state their culture will not allow most of their families members to accept Sarah's differences. Disclosure, gender assignment, surgical options, other scenario. How would you advise the parents to disclose her diagnosis? There is no clear-cut guidelines that one can. I think you have to use the family dynamics and parents, and gradually they should. I had a patient like this, and parents say, yeah, I must not tell anything to the grandparents. And I had no desire to, because I was dealing with the parents only. Now, children as young as 3 years were aware of their diagnosis and prognosis without ever being told by an adult. Adult avoidance of disclosure and denial of difficult information led the child to feel abandoned and unloved. Are you going to disclose it to Sarah? What is the best time? Don't know. Should a psychologist be involved in the process? Yes. What role physician play in gender assignment? I think that most of the time, a pediatrician is the one who is a family member like that. He should play a significant role. A specialist like pediatric endocrinologist, urologist, they also express their opinion. Should the parents wait to assign a gender until after Sarah demonstrated her desired gender role? No, because permanent imprinting is after 15 months or so. If the assignment given now, Sarah does not agree with the future, has the physician pass her on? No. What resources should be used to help her and family make the decision regarding the assignment? How long you wait for surgical intervention, like lateral resection? Most of the time it is not before 18 months of age, because there is no reason for doing that. Would surgical intervention help the child to have a more well-adjusted life without possible conflict between gender identity and genitalia? Yes. Would the possibility of decreased sexual function following the clitoroplasty for a female gender assignment alter your advice to the parents? Most likely not, because it's not proven. What resources should be used for this elective procedure. How about if it is 16-year female with virilizing CAH, status post cardioplasty, reared as female, now requesting gender reassignment? It has happened. And there is a book called I Am John. 9-year-old 46X patient with realizing CH, reared as a female, now requesting gender reassignment. It is too early. I would rather counsel and psychiatrist and psychologist. And now 4-year-old 46 patient with realizing CH after clarity, and it's proven that their permanent imprinting is there, so they are more like a tomboy, play with trucks and action figures like that. So in short, I have tried to raise the issues with you. Most of the time, I think there are no clear-cut answers, and we have to use our judgment, which may be right, or which may be not. That is why a collective judgment is more important. And I hope that I have given you some food for thought, and you may come up with some better answers than provided here. I am grateful for you for giving me this honor to give this oration. Dr. Shah.
Thank you, sir, for such a great presentation. It was a real learning experience. It has expanded our knowledge. We are very delighted to have our guest of honor, Dr. Banani. So this is our memento, which we are virtually presenting to Dr. Surendra Verma, sir, along with a shawl. We are very delighted to have our guest of honor, Dr. Banani Poddar, ma'am, with us. A very good afternoon, ma'am. I welcome you to the Foundation Day ceremony. Now, I would request Dr. S.N. Singh, sir, and Dr. Shalini Tripathi, ma'am, to kindly share the next oration and to please give a brief introduction about our dynamic and distinguished teacher, late Dr. P.K. Mishra, ma'am, and to invite the next speaker for the late Dr. P.K. Mishra oration.
It is my pleasure to introduce late Professor P.K. Mishra, madam. She was a great personality, teacher of teachers, my own teachers. She was alumnus of King George Medical College, Lucknow. After pursuing her post-graduation in pediatrics, she joined as a faculty in the Department of Pediatrics, KGMC, and in 1972, and she was head of the department from 87 to 98, and she also served as principal and dean of KGMC from 1992 to 1998. She was pioneer in establishing pediatric oncology department and neonatology department in this college, which was of first of its kind in this college in Uttar Pradesh as well as in northern India. She was a great teacher. It has been said that a great teacher is one who not only teaches lessons and topics, but who ignites the brain of a student and makes them inspire. So, Madam was one of such teachers. Professor P.K. Mishra oration was started by her husband, late Professor N.C. Mishra sir. And now I invite Dr. Salini to introduce the orator, today's orator, Dr. Harish Chelani sir.
Thank you, sir. A very good morning to all of you. So it is my proud privilege to introduce the orator for who is going to deliver Professor P.K. Mishra oration. Professor Dr. Harish Chelani sir is ex-head of department and in charge of newborn unit, Department of Pediatrics, Safdarjung Hospital and Vardhaman Mahavir Medical College, New Delhi. He is trained at Harvard School of Public Health, Boston for improvement of quality in health services. He has worked as consultant in SARC region for scaling up facility-based newborn care. Dr. Chelani has held key positions in various committees and task force of Government of India in over 35 years of his service. He has authored more than 100 research articles and book chapters. He has been actively involved in various high-impact research projects, both at community and at facility for more than 20 years, which was supported by WHO, Department of Biotechnology, and ICMR. So without wasting any more time, I request Professor Chelani sir to deliver Professor P.K. Mishra oration, and sir will be delivering this on the topic Zero Separation of Small and Sick Newborn from Their Mothers, Evidence to Practice. Welcome, sir.
Good afternoon, and first of all, it's really an honor and thanks, Madam, for inviting to this prestigious oration. For a person who was a great academician, humble, and at the same time very simple. Very rare to find such people. Another common thing which I find that when I joined as head of the department pediatrics, in fact, the pediatric oncology and the neonatology unit were developed not only from the clinical service provision, but also from the point of the research. And I find that coincidence and the combination with Madam, and it is a great honor to present before you. And this oration I dedicate to the KGMU. Zero separation of small sick newborn. We all know conventionally, globally, all over the world, whenever the sick babies or small babies are admitted inside the newborn unit, the moms are either discharged or they stay in the postnatal ward. When I was looking at the literature, a psychoanalyst, Winnicott, said, there is nothing like a baby. There is always a baby with someone else. And that someone else would be the best person with the mother or some caretaker. So, what I'm going to discuss with you now, the research which we
did as a part of multi-country research, and we involved the mother's bed inside every sick baby in the NICU. Do you think it is going to be an emotional concept which I am going to talk to you, or there are hardcore benefits, and how that concept has translated into the guidelines and policy? Today I'm going to make a case for zero separation of not only the stable babies but also the sick babies. We all know this problem that more than 95% of the low birth weight babies are born in the low middle income group countries, and they are responsible for 70 to 80% of all deaths in the neonatal period. And not only the mortality, whether they are going to have the intact survival in the community. That is also one has to look into it. We all know this million death study, and with in the last 2 decades of the efforts from all the healthcare providers and the government and the managers, program managers, we have seen the decline in the rates of the asphyxia, if we talk about overall rates of it, and the sepsis. But what you can see is the persistence of the problem of the prematurity or the growth retarded babies. Do we have the high powered interventions? Yes, we do have. And when we look from the preconception till discharge, or we look at the 6 pillars of the India Newborn Action Plan or every Newborn Action Plan, if I want to have to invest on the 2 areas, I think care around the birth and care of small and sick babies would be more beneficial, because maximum number of babies which we are losing is around these periods. So if I invest at these areas, then we are going to have the SDG goal of single digit neonatal mortality by 2030. Do we have the intervention as we are saying? Yes. So I will focus mainly for small and sick babies. We do have antenatal corticosteroid for the moderate preterms. We also have the introduction of the CPAP now in the revised facility-based newborn care program. Let's learn about what is the status of the kangaroo mother care, which is a very key component in the care of the package of the small and sick babies. Currently, till 17th November, we had the WHO guidelines of 2014, where kangaroo mother care intervention is recommended for babies below 2000 gram, and also brief sessions of KMC to be started while the baby is improving in the newborn care unit. And once the baby becomes stable, then you start KMC in the KMC ward. And what we know that there is a 40% reduction in the mortality, apart from the other benefits in the reduction in the sepsis and in the hypothermia. And this is what we practice currently, that we are giving KMC skin to skin contact only for term babies, which are also stable babies, and there is only intermittent presence of the mom inside the NICU. In fact, in the study in 16 districts, it was found that average entry of mother is 3.8 hours and 1.7 hours is spent in the KMC. But what we are missing is the skin to skin contact of low birth weight babies, both for stable and the sick babies, and there is no presence of the mother 24/7 inside the NICU. So when we looked up the data and this information, what we found in the Cochrane review that KMC, which showed the reduction in the mortality by 40%, the mean age of randomization was 3 days. And by that time, most of the deaths of the premature babies have already happened without receiving the intervention of kangaroo mother care. So the hypothesis was there. Does continuous KMC initiated right inside the labor room and continued till discharge has got any impact on the survival? With this, we had to, putting the sick babies on the KMC, one must have some data on the feasibility. We had 2 studies, one from Vietnam and another from Cape Town, which showed that these babies, they get stabilized better as compared to the, brought in the incubator or in the tray, which has been the conventional way of bringing the baby from labor room to the NICU. So with this background, the World Health Organization started immediate kangaroo mother care study, which involved these 5 countries. And Delhi Safdarjung Hospital was the only center from the Asia. And we, in a randomized controlled trial, we took the population of 1 to 1.8 kg, and KMC was initiated immediately after birth, while the control group babies received the conventional treatment. And what was the intervention? Intervention was starting KMC within 2 hours, because initial some time would be utilized in resuscitating the baby. So within 2 hours, and plan to give as long as 20 hours. Also support for the breast milk feeding, because these are the small and sick babies who will not be able to suckle effectively. So support was provided. And since these babies are going to be with the mother, so minimum or essential care package for the moms and the baby was also provided. So to operationalize the whole thing, starting KMC from birth till discharge, we have to have concept of immediate KMC in the labor room, transporting in the KMC position, and making the mom and baby together. So we created the mother newborn intensive care unit. So this is as many of the places, but the stable babies are put on mom's chest, but preterm and sick babies, they are brought inside the, brought under the radiant warmer. So in this, even the babies were dried on the mom's chest and transported in the KMC position. But since mom is still there and baby is to be shifted to the newborn care unit, so we utilize the surrogates already identified by the moms. And you can see that even the babies were shifted with the CPAP along with the pulse oximeter with the surrogates. This is the snapshot of the mother newborn care unit, which you can see. It is a 12-bedded unit which was made, and now it is still after the completion of this study in 2020, it's being continued, the services. So there is a mom's bed. I can show you this is a 12-bedded, so picture of 1 cubicle. So you can see the mom's bed. There is a radiant warmer, CPAP unit, and level 2 facilities care. So here in this study, the critically sick babies who require the ventilatory support within 2 hours or babies in shock were excluded. Since these moms are going to stay with the babies for many days, maybe 7 days to 21 days or even 2 months, so the support for the moms also was provided. Mother's examination cubicle, the bathing and the washroom facilities. So coming to the data, actually the results which you can see, I hope you can appreciate from the back, otherwise I'll say. The mean birth weight was 1.5 kilogram and mean gestational age was 32 weeks. And what this difference which you can see, very large sample, 1,600 babies in each group. The intervention babies received the KMC within 1.3 hours after birth, whereas control group, as per the WHO guidelines, received KMC only after mean of 53 hours. And you can see that while in the mother newborn care unit, 17 hours was KMC provided, while in the NICU, it was just 1.5 hours. Once they become stable, they went to the current guidelines and they received around 19 to 20 hours, the KMC. Let us look at the primary and secondary outcome, major difference. You can appreciate that there was 25% reduction in the mortality. In fact, the sample size was calculated for only 20%, but the difference was so large that ethics board, DSMB board said that we have to stop the study because you can't deny the treatment to the control group. So the study was stopped 3-way, and you can see the difference of 25% reduction in the mortality. Those babies who are just kept onto the mom's chest right from the beginning. Reduction in the hypothermia and the sepsis rate. The apprehension which most of us will have, the presence of mom inside the NICU will have higher mortality, higher infection rate. Whereas if you see the scientifically, it is a microbiome, which is the same microbiome which is going to have early exclusive breast milk, no hyperthermia, no hypernatremia, which happens in our NICUs in the radiant warmer. So mortality was reduced by 18%. At least it was not increased, which the apprehension was there. Even the breast milk indicators, you can see early availability of the milk, or by 7 days, or by 28 days, or at discharge. These babies, they will have the better breastfeeding rates. So the study concluded that there has been a reduction in the mortality by 25%. Those babies where we started KMC right at birth or within 2 hours. Second important thing is, if you convert it into that, if you provide 27 babies KMC, you are going to save one life. And if you translate them in the global scenario, you are saving 150,000 babies additionally by this intervention. So, does this mother newborn care unit is going to change the paradigm of care of small and sick babies? One has to see, and one has to see the WHO guidelines. What are those? I'm going to discuss with you. What is the neuroscience when we are saying this? Mom's baby is shifted from the incubator to the mom's chest. What is the neuroscience behind all this? If you see, brain stem is under the sympathetic dominance during the stress, right? And sympathetic nervous system causes irregular cardiorespiratory status. So these babies are more stabilized in the KMC position because they are, shifted onto the parasympathetic tone. So when separated from mom and they are not in KMC position, brain remains under the sympathetic dominance. Now what happens when you minimize the separation? The cortisol level goes down and the catabolism is less. These babies, they gain weight better and their hemodynamic stability is much better. In fact, in one of our postgraduate, the PhD thesis, we quantified the stress both in the mom and the baby by doing the salivary cortisol levels. And we found salivary cortisol levels is much less in babies and in the moms when they are together. These are the major issues, and which I'm sure if you also start creating mother's bed in the NICU, which is against the current norms, even in the West, nobody would go for it. Then concern regarding the increased infection. And imagine mom is there inside the NICU have a wonderful relationship with the obstetrician to take the round by them inside the NICU. It's not an easy unless there is a very happy marriage between the two departments. And then increase accountability of the healthcare providers. I remember when we started this study in 2017, no, it's fine. When we started this concept of zero separation, the concern came from healthcare provider that there will be a mother sitting in the NICU, so there will be increased accountability. Yes, but there are benefits also. So how these challenges we took the each one by one. To start the KMC in the labor room, we already had the surrogates, and fortunately in India's culture, the females are more than 18 years. Mami, chachi, masi, anybody, who can be there, and they are usually there. And in the government's program also, Lakshya, we are allowing the person physically present in the labor room as a part of the respectful care. So these surrogates were there who could transport these babies, sick babies, onto their chest till the mom is available after the first few hours after birth. So that was made available, and you can see that the moms were, the babies were transported by the surrogates, even the sick babies with the CPAP and the pulse oximeter. Another challenge was optimizing CPAP sick babies in the sick babies in the KMC position. So special garments were procured and they are available now, and we have put in the consumables that fixes the neck of the baby so that they do not go into apnea, and with the continuous monitoring of the heart rate and saturation, we could overcome these challenge. This is the binder which you can see, the inner white binder which you can see on the left side, that is to stabilize the baby's neck. And the outer garment provides the privacy as well as the baby doesn't slip down. So that was the garment which has been used, and now we are using even after the study. So the experience of the KMC transport, we also analyzed that data, and we could find that 70% of the babies could be shifted in the KMC position. Of course, most of them were the surrogates, with the surrogates. It is efficacious because 98% of the babies, when they reached the newborn unit, they were euthermic, normal body temperature. That is the criteria which we require. And they were much more stabilized. You can see that they were having less desaturation, and there was less severe chest indrawing and less nasal flaring. There had been a concern of the increased infection when you keep the mother's bed inside the NICU. But I tell you, this is our concerns of the healthcare providers. Moms, they learn, and no mom will try to pass on the infection to the baby. So she would be much more careful in handling that. And in the literature also we found presence of the mother inside the NICU does not increase the infection. And we looked up this data again. And for suspect sepsis, 18% reduction between the two groups. And if you see, 23% reduction in the case fatality. So that concern is no longer there, rather the mortality is less. And because these moms are together, so we discussed this when we were planning this study, we discussed with the obstetrician, and obstetricians, they supported us, and they are taking now regularly round inside the NICU as they are doing it in the postnatal ward. Neonatal nurses were trained to provide the postnatal care for the moms also. So this is a kind of a couplet care. Now we see obstetrician, they are more concerned about the babies, and the pediatrician, they ask about the health of the moms. So it's a kind of a couplet care which we find. it is more developmentally supportive. I see in the previous years when the babies are inside, of course, there are many apprehensions in the mind of the mothers that we are giving the babies to the hands of the stranger. What they are doing inside, what procedures are being done. At least now the mom is right inside. She can watch what is being done and she can be supportive. And in fact, a lot of task shifting, a lot of work of the healthcare provider, which is being done by the nurses, like diaper changing, expression of the milk, giving through the cup feeding. These tasks all can be done by the mom, and the nurses and the healthcare provider can, put up this time more for monitoring the sick babies rather than the other jobs. And now we are following this cohort for next 2.5 years. We have completed this study to look into how these babies are neurodevelopmentally behaving, whether these babies are better neurodevelopmentally or not. So we are waiting for that data. So this has been our experience, that there has been a less anxiety, there is a better parental satisfaction, and staff is less worked on. So this is the summary of that, what I was saying, that immediate kangaroo mother care, where we could give more than 17 hours of the, togetherness, and it is efficacious, 25% reduction in the mortality, it is safe, and it is acceptable. We were also continuing, we were apprehensive even in the COVID times, and you must have seen the data of the WHO, the presentation, mathematical modeling, how many babies we are going to lose if we, in the COVID times, we separate them. So after the screening, we were also providing the KMC, even in the COVID times. Of course, there was a separate unit which was made. Now we know the evidence. What should be the next step? You must have seen this on 17th November 22, World Health Organization revised the guidelines based on this evidence, and also another study which came, community initiated KMC. Small babies below 2,500 gram who are not critically sick, except those babies. Otherwise, moderately sick babies are also to be provided KMC. Previously, minimum definition of KMC was 1 hour. Now, effective KMC definition is 6 to 8 hours. And you can see these things are available, these documents. And already we are working on these additional documents. These are the guidelines which are available. To implement this, you need the implementation strategy, and global position paper on KMC is also on way very soon. Now, how to scale up this concept of mother newborn care unit or zero separation? We already have the now WHO guidelines, and very soon the government of India, fortunately the government of India in 2018 already sent the guidelines to the state ministries health that all future units should be now mother newborn care units of level 2 care. Friends, we as a health care providers, we had been providing the care in a conventional way, but with this new evidence, we should shift our policy of keeping the mother and baby together or having a zero separation. For that to happen, the hospital has to make a change in the policy. Currently, mothers and surrogates, they are visiting the NICU only for a brief interaction, or mothers are allowed every 2 to 3 hourly. They don't stay with, baby. Mom is staying after delivery for 2 or 3 days till the baby is sick in the postnatal ward, and we tell them to come and provide the KMC and give the milk. It's not an on-off switch. Mother has to be with the baby right from birth. Only then these processes can happen. So to make zero separation a reality, we need to have the infrastructure change. We need to have the process change. We need to have the collaboration between the two departments, and most importantly, the mindset of the health professionals So friends, I end my talk by saying that zero separation is a paradigm shift for the care of small and sick babies. And once again, thanks for giving this honor to present this prestigious oration. Thank you very much.
Thank you, sir, for your wonderful deliberation, sharing your work and your thoughts. Thank you, sir.
We would like to extend a warm welcome to our respected chief guest, Honorable Vice Chancellor of King George Medical University, Lieutenant General Bipin Puri, sir, to the auspicious Foundation Day ceremony of Department of Pediatrics. A very good afternoon, sir. We are blessed to have you here. We would like to request you and ma'am to kindly felicitate Dr. Harish Chilani, sir, for the late Dr. PK Mishra ma'am oration with the shawl and memento.
May I request, since the Lions Club governor and the governor has come and the members have come, we are requesting Honorable Vice Chancellor to come outside for 5 minutes. The rest are requested to keep seated. We will inaugurate and then come for our Foundation Day ceremony. So please. संजय एसी चला आई एसी चला दी
I welcome all of you back to the Foundation Day ceremony. Now, I would like to request Dr. Shelly Vasti ma'am to kindly invite the dignitaries to the dais.
डॉक्टर चलाने हाँ हाँ
I would request dear residents to please present the floral welcome to the dignitaries. Dr. Nikita to please welcome our chief guest, Honorable Vice Chancellor Sir. Dr. Sain to welcome our guest of honor, Dr. Banani Poddar ma'am. Dr. Simran to welcome Dr. Harish Chilani sir. Dr. Twinkle to welcome Dr. Shelly Vasti ma'am. Dr. Adhyati to welcome Dr. S.N. Singh sir. We also welcome the distinguished heads of other departments like Surgical Oncology, Dr. Arun Chaturvedi sir. Dr. Simran to please felicitate Dr. Arun Chaturvedi sir. Dr. Abjeet Kaur ma'am. Dr. Suryakant sir. Dr. J.D. Rawat sir. Our respected CMS, Dr. J.D. Rawat sir. And to please felicitate our respected CMS Shankar sir. I am very thankful to all of you for gracing the occasion. Nothing is possible without God's will. What better way to commence our ceremony than invoking God's blessings? May I request Dr. Dhruvi, Dr. Ashwini, Dr. Parul, and Dr. Vanshika to come for the Saraswati Vandana to invoke the goddess of learning.
या कुंदेन्दु तुषार हार धवला या शुभ्र वस्त्रामृता या वीणा वरदंड मंडित करा या श्वेत पद्मासना
हे शारदे माँ, हे शारदे माँ, हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। तू स्वर की देवी है, संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। तू स्वर की देवी है, संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। हम हैं अकेले, हम हैं अधूरे, तेरी शरण हम, हमें प्यार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। ऋषियों ने समझी है, मुनियों ने जानी, वेदों की भाषा, पुराणों की वाणी। मुनियों ने समझी है, मुनियों ने जानी, वेदों की भाषा, पुराणों की वाणी। हम भी तो समझे, हम भी तो जाने, विद्या का हमको भी अधिकार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। तू श्वेत वर्णी कमल पर विराजे, हाथों में वीणा मुकुट सर पे साजे। तू श्वेत वर्णी कमल पर विराजे, हाथों में वीणा मुकुट सर पे साजे। मन से हमारे मिटा के अंधेरे, हमको जालों का संसार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। 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 थैंक यू।
Now I would like to invite Honorable Vice Chancellor Sir and the respected dignitaries to proceed for the lamp lighting ceremony. Next presentation introduce करूंगी. We would also like to welcome Dr. D. Himanshu sir and Dr. Neeraj sir. It has been long since the foundation stone for this department was laid on 14 November 1954 by the then CM of Uttar Pradesh, late Shri Govind Vallabh Pant ji. And look, today we stand here to celebrate the 69th Foundation Day. What a legacy! But we should remember that with every opportunity comes responsibility and accountability. So, to take account of our achievements and shortcomings, and to prepare a ground plan to address the previous challenges and to strive towards the new set goals, we have to look at it. So, it gives me immense pleasure to call upon our dynamic head of department, Professor Shelly Avasthi ma'am, to welcome the dignitaries and also to present the departmental annual report.
While he's putting the annual report, Sanjay, पीछे के ACs चला दीजिए, पीछे के सब चला दीजिए. Honorable Vice Chancellor of King George Medical University, Lieutenant General Vipin Puri. Our guest of honor, Dr. Banani Poddar, Head of Critical Care Medicine, SGPGI, who happens to be a pediatrician and a close friend of our department. Professor Harish Chelani, who is the former head of Safdarjung and is instrumental in establishing neonatal services evidence-based in our country. Dr. S.N. Singh, professors, senior professors, heads of departments and administrators, faculty, students, nurses of King George Medical University, Department of Pediatrics. As Dr. Arisha said, the foundation stone was laid in 1954. And historically, I checked what was the infant mortality. That was 271 per 1,000 live births at that time. What is it today? As I stand here, it is 27 per 1,000 live birth. So India has made a tremendous change and a tremendous leap. And we as a department were established then, our significance was tremendous. Today, our role will be the same, but it will be modified, and we want to march with the changing times. Our departmental vision, therefore, inspired our Vice Chancellor, is to promote academic and research culture in the faculty by facilitating their respective subspecialty. Yeah. If people want, they can turn back, sir, or if you want, you can go down as you wish, sir. Yes, sir. Please, sir, come down, sir. So our departmental vision is we aspire to promote academic and research culture in the faculty by facilitating their respective subspecialty interest. Because from 271, we have come down to 27. Encouraging their registration in PhD and advanced study program, applying for extramural fundings, and understanding and using contemporary educational methods for imparting training to students. This will ensure quality in clinical and academic pursuits, and it will benefit all stakeholders. Humbly to state, we were adjudged Best Clinical Department for the year 2021, and the legacy continues. The 68th Foundation Day, NL Sharma oration was given by Dr. S.K. Kabra on cystic fibrosis, and P.K. Mishra oration was given by Shubha Phatke, More for Rare, an era of monogenic disorders. Today, we are 13 plus 1. The plus 1 is a contractual ad hoc faculty. We are waiting for more to join us because we need many more. We have 27 sanctioned SRs. We have 26 GR3s, 26 GR2s, and out of 26 GR1s sanctioned, 25 have joined. For the new faculty, let me introduce Harkirat Kaur. A big round for her. Harkirat is contractual. She's designated assistant professor. She's done DM neonatology, posted in Department of Pediatrics. She is looking after the NNU, and we have great expectations from her. The functioning units, when we began, the department began in 1959, 62. There were 20 beds. Now we have 6 units, PICU, NICU, NNU, oncology, 285 from 20. So there's a huge leap and a lot of work is being done. And in terms of patient care, you can see that in the OPD, we have approximately 50,000, 40,000 attendants. There was a dip during COVID time. And in the inpatient, approximately 10% of outpatients really get admitted to our department. Same for NICU and NNU. NNU was augmented by Honorable Vice Chancellor What Harkirat is saying today, ventilators 6, there were no ventilators. They came in the last 1 year. Dr. Chilani also visited the facility. So we have upgraded NNU, NICU. Besides that, we have augmented academic activities. Besides what everyone does, we try to do different. Maybe better, may not be better, but we try to different. We have alumni lectures round the year. This year, 5 alumni gave their lectures. We are proud of our alumni who have made a name for the department. They come and support us and support our faculty. In the third consecutive year, our own faculty, me and my colleagues, give a continuing medical education on pediatric updates for postgraduates. The third one was held this year. And here are all of us attending this update. Center for Excellence in Pediatric PB was established in our department by Honorable Governor Srimati Anandibai Patel. And Dr. Surikant is helping us in this. And we are looking after pediatric PB patients with assistance of Department of Dr. Surikant's department. Honorable Vice Chancellor has approved Center of Excellence for Endocrinology in Type 1 Diabetes. Novo Nordic Education Foundation will establish it, has begun the work, space has been earmarked, and we are very happy to see. You see our spectrum is changing. National TB elimination to non-communicable disease mandate. The key outcomes are awareness, improving overall understanding and care of type 1, capacity building, very ambitious, 1,000 doctors, nurses, ANMs, Anganwadis for better and improved care of type 1 diabetics will be done. And we will develop a diabetes registry, launch data analysis, and augment publications from our department in collaboration with our colleagues. We have, in a very important way, started interventions to improve our PICU. We have support from AIMS, and we will request support from Dr. Banani from SDPGI. We have started AIMS monitoring sheets implementation. We plan to start fellowship in pediatric critical care or ICU, whatever we call it at the earliest. And immediately, major ventilatory changes are done by faculty, minor changes by senior residents, and we are trying to do better resource utilization of HFO, USG in patient management. We invited Dr. Armin from our own critical care. They are supporting us, and we had a series of lectures for our residents by Dr. Armin in this department on ventilator. Similarly, our SNCU, we provide neonatal intensive care, we do delivery room care, we do screening, point of care, ultrasound, 2D echo, hearing, rope screening with Department of Ophthalmology and ENT department, and we educate our residents. There's a tremendous scope for improvement, and we are happy that Dr. Chilani has helped us, and he will hold our hands for improving that. So what do we plan to do in our SNCU? Institute evidence-based management of surgical and medical conditions, collaboration within ourselves and outside, within and outside India for improved care, training of our residents and our nurses, and complete follow-up. So this is a tall mandate, and we are requesting Honorable get faculty for the Department of Neonatology. Then we may consider contractual faculty to help Harkirat and others take the mandate of neonatal survival to its meaningful achievement. What are our faculty achievements? Proud to say, Nishant Verma was adjudged popular teacher by students poll. We are very proud for that. Dr. Neeraj Anand, who has newly joined, Honorable Vice Chancellor sanctioned extraordinary leave, has spent 6 weeks in All India Institute of Medical Sciences. Yesterday I was there, I met, the faculty was happy, and Dr. Kabra and Lodha promised extended hand-holding, Neeraj Anand. They will monitor you and they will help us in improving our ICU services. I got a commitment from them yesterday. Shalini and Sarika were awarded the Fellowship of Medical, Membership National Academy of Medical Sciences. I have been selected as a member of Technical Advisory Group for WHO Health Security Interface Committee in Geneva. Sarika has been selected National Advisory Board member of the journal Research and Reviews in Pediatrics, and she has become executive member for Respiratory Chapter. She got a second prize in oral presentation, TB and other chest infections in NAPCON 2021. So what in research? In research are in last 1 year, 31 publications, 38 ongoing projects, 8 international collaborations with University of Oxford, Edinburgh, Cincinnati, Manitoba, Swiss TPH, PATH, BMJF and WHO, 18 national collaborations, 15 internal collaborations which are most important with lab side, gynae, cardio, pulmonary, ophthalmics, pulmonary medicine, respiratory medicine, SPM, radiodiagnosis, pediatric surgery, 5 MOUs, and we have 7 chapters in books. The H-index, the highest H-index is 58, and everyone aspires to go 100 and above. That's my target. For the 4th consecutive year, one of our faculty has been adjudged in top 2% scientists in India, and Honorable Vice Chancellor has felicitated me. Now, we formed the Georgian Pediatric Trust in 2020, through which we run the alumni series of lectures, and our alumni closely interact with us, not only closely, emotionally interact with us. We have CMU unit pediatric updates for postgraduates. This Foundation Day program is also partially supported by our trust and by so many other pharmaceutical companies, which we acknowledge their support. We give prize to best workers. We give to those patients जिसका विपन्न और असाध्य नहीं बन पाता किसी कारणवश. We support them through our trust, and we do regular audit and accounting as is supported. We did polling for the best staff. An election process was held for hardworking staff, and the results will be declared best nursing staff, best ward boy, best class 4. This was held on 16th of November. 45 old residents voted with zeal. The 25 new ones, we did not allow them to vote because they only had 1 week exposure to these people. In undergraduate teaching, we continue our teaching on NMC competencies. We have skill modules for UG evening teaching. We have small group teaching. We have PPTs and standardize all our teachings. So if today you say that I'm not there, X has to teach, that X will know exactly what is the lesson plan. So what we have done is these SOPs will ensure that there is continuity and that the standards will improve year by year. We have UG quiz. In the postgraduate teaching, we have a teaching strategy for postgraduates. We have revised our logbooks, and the revised logbooks will be sent for printing. And like everyone else, we have case conferences, which are skill-based, seminars, small group discussions, audits of PICU, NICU, oncology, pediatrics. We try to strengthen communication skills of residents, and we have a monthly Viva with team posting. We do mini CX of all the students who are with us and give them feedback. Now, the PG activities were quizzes. They have won state rounds of quizzes. They have won they got second position in central zonal round. One of our residents was in top 8 in the best IJP PG thesis, Dr. Anshika Mishra. She's there in All India Institute with Kabra Ludha. And I think that is Jayashri, ne? Jayashri, yes. And a class on pediatric advanced life support system was organized by here. Dr. Banani will bear with us that we do our own PALs here because we don't take money from them. We do our PALs, we do our newborn, and we do BLS. And we do it several times a year for them. Now, 14 papers and posters were presented by our resident doctors. I'm not naming them. We are proud of all of you. Continue to do that. And I also ask you, go beyond poster and paper presentation to publication. Complete the whole journey. Don't leave it half. These are the papers and posters presented. And at the end of it, we celebrate a lot. World Pneumonia Day, World Breastfeeding Day, Nukkad Nataks. World Diabetes Day, Children's Growth Awareness Week, ORS Day, Cancer Day, Teachers Day, name it, and we are ready to put ourselves together. International Childhood Day celebration, Women's Day celebration also, and of course the Holi celebration, not to miss that. We are proud to say that for the first time in my remembrance, one of our sisters, Mrs. Archana Sachan from department, was awarded SKD Distinguished Sister Award. She is in PETC. A big round of applause. खड़े हो जाइए आप लोग को अर्चना. I request all the nursing staffs, all the sisters in charge to emulate her and try to do what she does and do it better. Thank you very much. Under the chairmanship, leadership, Honorable Vice Chancellor, funded by NHM, ECRP2, we will be establishing 42-bedded pediatric care unit on the 4th floor of Oncology building and 12-bedded pediatric ICU just above this. And we will have a pediatric center of excellence, a hub and spoke model. What are our departmental best practices you would like to know? We meet very regularly. All ideas are discussed and we do a consensus work, whether it's teaching, learning, patient care or celebrating. We have a robust contemporary teaching program which we all contribute, and we have the trust. We always say we have something, a small pockets, not very deep, but we are not bankrupt at any time, and big hearts. So we do that. So what are our departmental distinctiveness? The Human Milk Bank. First in UP and Northern, perhaps not, आपके पास भी है दिल्ली में मिल्क बैंक. तो first in UP, Human Milk Bank, subspecialties oncology, neonatology and OPD is running. 2 faculty are PhD, 2 have enrolled. 1 faculty has PDCCN fellowship. Dr. Punya has cleared DM nephrology and he's a faculty, Dr. Punya. And we have SOPs and standardized materials for teaching and training. Our SWOT, we have been best departments, we have research and publication, we have SOP for teaching, we have faculty. Opportunities, we are largest pediatric department, we develop specialty. We need more teachers, we need equipment, but more than equipment, we need care of equipment. And the care of equipment will require more brainstorming on how to ensure that the equipment are taken care of in an adequate time, because simply doing AMC, CMCs is not sufficient. It's beyond AMC and CMC. And the threats, the threat I should remove, they have not de-recognized our MD seats. We were few faculty short, now our faculty shortage will fulfill. The patient volume can be a threat also if it spreads infection. So we have some targets for next year. We really seriously are thinking of strengthening our ICU services, whether it's PICU or NICU or SNCU. Because now any change in the SDG will be by saving critically ill. The less critically ill do not come to us. Only the critically ill come to us. NCD, the forward mandate is NCD and non-communicable disease. And type 1 diabetes, thalassemia, hemophilia, cancer, name a few, we are tackling these NCDs. We have to be more aggressive in that. We will augment our academic vibrancy. And what we wish our USP would be patient-friendly, child-friendly services. Thank you all very much for being here.
Thank you, ma'am, for such a lovely and lucid presentation. The talked about milestones can only be achieved through coordinated efforts between doctors and the staff. The hard work and sincere dedication of our staff members is duly appreciated and has been officially recognized through a polling process which was conducted under the supervision of Dr. Arpita ma'am. A total of 45 students, as told by ma'am, voted with great enthusiasm to adjudge the best staff across the various categories. So I would request our Honorable Vice Chancellor, sir, and Professor Shelly Avasthi, ma'am, to kindly honor them. The award for the best nursing staff goes to Mrs. Sunita Chaudhary, who is currently working in NICU. She is recognized as a hardworking, cooperative, humble, and a responsible person. The award for the best ward boy goes to Mr. Mahinder. He is currently posted in PICU. He is known for his hardworking, joyful, and enthusiastic nature. The award for the best class 4 worker goes to Mr. Subedar, who is currently working in PICU. He is identified as a soft-spoken, laborious, and helpful worker. Now I would like to request the dignitaries to please take the seats on the dais. I'm indeed honored to introduce the guest of honor. Dr. Harish Chelani, sir, gave a wonderful oration on zero separation of small and sick newborns from their mothers. It was very enlightening, sir. We are indeed very proud to have you here and would like to request you to please share key take-home messages.
Thank you, dignitaries on the dais and the teachers and fellow colleagues. First of all, it's really an honor to be here, but I would also feel and take the point from the presentation from Dr. Shelly Avasthi that, we have come a long way to reduce the neonatal mortality. Now, if we have to come to a single-digit neonatal mortality, then we have to work even much more because it is a last push, which is a greater effort which is required. And second is the point which I take from her is the volume load. Naturally, when the department or the institution provides the good service, naturally the referrals are there. In fact, we are also looking at Delhi, that model of, mapping the care and decentralization of the care. Because when you look in any hospital, and when I visited here, there are many patients which can be done at the district and the sub-district level. But because of the, the facility is providing the very good service, so people, they get there. So if we can create a model of mapping the services, decentralization, I think that would be better and load would be less. And the people here, which I feel they are so passionate about the work, they can, utilize their time in providing the quality service, and we can look forward for starting the DM course also in the near future. Second, I feel survival is one thing, but then we should also see whether we are seeing the intact survival. Whether how these children are going when in the community, they are going to have a intact survival, good neurodevelopment outcome. So where we need to have the stronger, the infrastructure in place, and I was saying, it's not that this zero separation is a passion for me, but I feel this is a thing which is a more physiological. And that concept, we have got enough space, we can create that kind of unit and we provide respectful care both to the babies and the mother. I think if we keep these things, there are of course many things, but these are the few simple doable things to start with, and we can achieve definitely the SDG of single digit NMR. Thank you.
Thank you, sir, for your wise words. I am indeed honored to introduce our guest of honor, Dr. Banani Poddar, ma'am. She's an extremely distinguished name, very dynamic, a great teacher, and a wonderful orator. Ma'am has done her graduation from CMC Vellore and post-graduation from PGIMU Chandigarh. She's also been an overseas fellow at Pediatric ICU at Royal Children's Hospital at Melbourne, Australia, and also a fellow of American College of Critical Care Medicine. Presently, ma'am is heading the Department of Critical Care Medicine at SGPGI Lucknow. She has over 50 publications to her credit in esteemed journals and is also an associate editor of Indian Journal of Critical Care Medicine. We are extremely privileged to have you here, ma'am, and I kindly request you to please address the August gathering.
Good afternoon, everybody. And at the outset, I'd like to thank Ma'am Shali Avasthi and her entire team for inviting me here. And actually, it's my honor to be here rather than an honor for the department. And perhaps this is a kind of a memory I lived through because we've done at least 2 PALS courses here and also had another foundation day at which I presented a lecture on probably fungal infections or something like that. So thank you, ma'am, and thank you, Department of Pediatrics, for inviting me here today. And also, it's an honor to share the stage with 2 very distinguished people, Professor Harish Chelani, whom we heard speak on neonatal care, a unique concept of zero separation, and Lieutenant General Puri, who is the Vice Chancellor of this institute, and who I discovered to my pleasant surprise as we were at the PGIMU Chandigarh at the same time. Unfortunately, I don't know if we had some adverse interactions because that always happens between pediatric medicine junior residents and DM or MCH pediatric surgery residents. So while I thought that I'd take this opportunity to talk to the young minds here and implant one more idea. You're getting a lot of ideas today, and I wish that some of you would carry this forward. I'm proud to say that we as pediatricians practice a branch of medicine which not only deals a lot with curative services, but we also have a lot of preventive services which are kind of ingrained into us. We do a lot of nutrition, we do a lot of vaccination, and so on and so forth, all of which is we monitor growth of children and, intervene early and tell them that they're faltering off the growth charts, etc. So preventive medicine is inbuilt into us. So this is one thought that India is really suffering a lot because of infections. We do great jobs at treating patients. We operate them well. We take them through fantastic procedures. The skill of the operating surgeons or the interventionists is fantastic. But where we lack is our infection prevention. A huge burden of hospital-acquired infections is what we face. And unfortunately, India has been designated as the infection capital of hospital-acquired infections and resistance. MDR bugs are everywhere. So today, I'd like to request all of you to practice preventive medicine as far as infections are concerned. So think a lot about hand hygiene. It is easily doable. It's the cheapest intervention that can be done. All you need is to wash your hands. We all did it so much during COVID, and then the minute COVID is gone, we've stopped. I think we should just promote this practice of hand hygiene and think that it is your hands which are infecting others, and maybe you carry that infection back home and to yourself. So this is one very cheap intervention that can be easily practiced. Think rationally about antibiotics. I came across a very elegant comparison between hand hygiene 5 moments and 4 moments of antibiotic prescription, and I'd like to say it here. So when you sit in the OPD and you want to prescribe an antibiotic, just ask yourself 4 questions. The first question is, am I really dealing with infection? Is it possible that there is something else that is lurking there? And am I actually working up this patient appropriately, doing some tests? The second question is, what would be the best antibiotic under the circumstances, given the situation that the patient is coming in, right? The third is probably not possible in the outpatient, but something that we can do in the ward. 2 days have gone by, you have observed the patient on that particular antibiotic, you have a few tests which have come back, and how would you like to modify your antibiotic policy? And the last question is, here we have all the tests, you have seen the course, you know the diagnosis, you probably have the culture reports at the end of some 5 to 7 days, and now you need to decide about the duration of therapy, because duration is very important. If you undertreat, you promote resistance. If you overtreat, you promote resistance. So you have to get it right. So these are the 4 moments of antibiotic prescription, which would be very important. And of course, all the other paraphernalia that comes with infections, which means a good lab, appropriate cultures, or at least rapid diagnostics, and not treating every fever or not jumping that every worsening is an infection. The other aspect that I'd definitely like to draw your attention to is that we have heard so much about neonatal care, and India has taken rapid strides in neonatal intensive care. Unfortunately, pediatric emergency and pediatric critical care has lagged behind, and I'm really glad that ma'am has taken that upon on a war footing, it seems like. And really, this can make a lot of difference. We have seen patients with dengue, we have seen patients with scrub typhus, we have seen patients with meningitis. All these diseases, infections, and even simple things like henoch-Schonlein purpura, hypertensive emergencies can all be managed, and definitely they can be managed without morbidities. And most children who go into an ICU come out if we do not do bad things to them. So this is the other challenge that I'd leave you with, that pediatric critical care needs to grow, pediatric emergency needs to grow, and a large part of our practice is also emergencies. So hone your skills in pediatric emergency, pediatric critical care comes automatically, and always think of ways and means to prevent infections. With these words, I'd like to thank you once again, ma'am, for asking me to come over here. Thank you very much.
Thank you, ma'am, for your kind words of enlightenment. It is my proud privilege to introduce our chief guest, Honorable Vice Chancellor of King George Medical University, Lieutenant General Vipin Puri, sir. He has served armed forces and has retired from the apex position of Director General Armed Forces Medical Sciences. He has spearheaded the medical research program of armed forces and brought synergy of the clinical and basic research with DRDO. He has been a renowned member of Governing Council of ICMR and NBE, and also he's a chairman of International Congress of Military Medicine. He has received numerous medals for his exemplary service, including Param Vishisht Seva Medal. We have been very fortunate to receive your valuable guidance over the past few years, sir, and now request you to kindly bless us with your precious words.
So, Professor Shelly Awasthi, HOD Pediatrics, but also most importantly, the Dean Research of KGMU. Professor Suren Verma, of course, he's not there at this point of time, but he was one of our very esteemed guests, the orator for today, Professor Harish Chilani, whom I heard with great awe and was very, very impressed by the concept of kangaroo mother care. Professor Banani Bodar, brilliant, absolutely brilliant neonatologist. Various heads of departments, Professor Arun Chaturvedi, faculty from Department of Pediatrics, residents, nurses, technicians, friends, ladies and gentlemen. My compliments at the outset to the Department of Pediatrics on their 69th Foundation Day. As I always say, Foundation Day is a day when you actually look back on your glorious past, the legacy of your predecessors, how much of hard work, sweat, toil, blood they have put into this effort to reach where you are today. Because when we talk of the current neonatal infant mortality, whatever we talk, a lot has happened in the past so many years. A lot of your predecessors have worked very hard. And I sincerely believe that our glorious past must be given the respect that they deserve. That is one. Two, is also time to introspect about your present. Where do we stand? When we do our SWOT analysis, when we look at our strengths and our weaknesses, how can we improve upon our present weaknesses and consolidate, of course, our strengths? And if you crystal gaze into the future, you should have time-bound objectives that I need to reach there by so time. So I think that is what I would want all departments, as when you do your commitments, when you do your foundation day exercises, this is what I would expect. Each one planning the future as much as you look at your present. So let me first also now, keeping to pediatrics, very, very proud the way this department has been over the years and has done in the last year or so. Of course, Professor Shaley talked about a lot of things, but I am in particular, I'm very, very happy the way things have happened, because a lot of subspecialties have started coming in. I'm very happy about pediatric nephrology, which has come in, and I think that itself is a shot in the arm. Besides, of course, various other subspecialties. Now you've got a assistant professor who's done a DM in neonatology. I mean, I would, as I keep saying this, that it's important that we develop our subspecialties and have verticals with centers of excellence. Now, these are very, very important. I'm very happy that Professor Shaley sent one of the assistant professors for training in intensive care to AIIMS New Delhi. So these are, to me, they may be baby steps, but they are very, very important steps. And I think that we have to continue to do capacity building of our staff and continue to improve and strive and try and do even better than what we have done. So so a lot of things have happened in this, what Professor Shaley talked about, whether it's the tuberculosis elimination program, whether it's a lot of things that they are doing in terms of improving their infrastructure. And of course, she very rightly said that the department got the best clinical department. And this is something I say this again to, in an open forum, I say this, that Professor Shaley is one head of department. I interact with so many of you all, but whatever she does it with huge amount of precision, with a lot of passion, and that is, I congratulate her for doing whatever she does exceptionally well. And I think that's become her trademark. What you give her a job and she does it to the best she possibly could. So I'm also very happy to see that there is 2 faculties are doing PhDs. Now that's another very important thing. Promoting the faculties, the young faculty members to do a PhD, and I'm very, very happy to see that. Of course, the awards will come to you. I sincerely believe that if you do well, if you are working hard, if you do your job, awards will just come to you without, you don't require to look at awards. They come automatically. So I'm also very, very pleased to see their publications, as she talked about, very high departmental H index, and all faculty members have been publishing, and that gives me great amount of satisfaction. I have to mention about these two wonderful orations that we had today, Professor N.L. Sharma oration by Professor Surendra Verma. Of course, he, has been a Georgian and has a special interest in pediatric endocrinology. And and of course, the late Professor P.K. Mishra oration, which was by Professor Harish Chelani, ex-head department from Sadhudang Hospital. So very proud, and so thank you very much. Deep gratitude for being here, for bringing out this lovely concept of kangaroo mother care and decreasing the separation time for these newborn. Can they make a difference as far as outcomes are concerned? So, friends, once again, congratulating the Department of Pediatrics on their Foundation Day. I leave you, the department, with a couple of thoughts, a couple of challenges in the coming year. As I always say, that specialty clinics, centers of excellence, should start mushrooming. You must have specialty clinics. Pick up areas in your area of interest and run specialty clinics where you improve the quality of care. That is one. Audit your NICU and PICU. Look at hospital-acquired infections, as what she said. I think that's critically important both in the pediatric as well as the neonatal setting. Hospital-acquired infections continue to be a big, major problem, even with us. And I think that is something which we require to introspect and see how we could. The third thing, of course, as I always keep saying, nutritional support in whether it's in the neonatal setting or in the pediatric setting. You win wars, you win lives, you save lives, critical care. So I don't know why you don't believe me, but believe me, it makes a difference. You give them good nutrition, plan, strategize, conceptualize good nutrition. You win wars, you win major critical problems. And I sincerely believe we should be looking at better strategies for nutritional support. And lastly, I make one more plea to the Department of Pediatrics. You have to save babies with congenital cardiac defects. I know it's a problem. I know it's a problem in North India where we don't have expertise for doing complex cardiac surgery in newborn babies. But I think that is a challenge. So that towards that extent, I have requested Professor Shelly that you to have a close group of assistant professor in pediatrics connecting with cardiology, which we have already done, and another professor in CTVS. And now I'm connecting you all to AIIMS New Delhi. I've already spoken to the director AIIMS. I have also spoken to the CVTS people. I'm going to connect you all so that I don't know whether we'll be able, even if I save one baby, I'm very happy. Abhi, at the moment, they're all dying. But can we save these babies is my challenge. I want to take it head on. And I will work on this, and I will assure you we will see the light at the end of the day. We will try our best to take this forward. So with these few words, once again, congratulating the department on their 69th Foundation Day. Congratulations for a job well done.
Thank you, sir, for your words of wisdom. Your constant guidance and support is a great source of motivation for all of us. It inspires us to become better each day. Now, I would request Honorable Vice Chancellor Sir and Shelly Vasti ma'am to please felicitate our guest of honor, Dr. Banani Podar ma'am, by presenting a shawl and memento to her. Now, I would request Professor Shelly Avasti ma'am to please present a plant to Vice Chancellor sir as a token of gratitude. Now, as we come to the end of the ceremony, I would like to call upon Dr. S.N. Singh sir to propose the vote of thanks.
It is a privilege for me to propose our expression of gratitude on this memorable occasion. We feel blessed to have Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri sir among us on this occasion. Thank you, sir, for being us, for your inspiring word, for your constant support and guidance. We are extremely grateful to our guest of honor, Dr. Banani ma'am, for accepting our invitation and gracing the occasion. And as Sally ma'am said, in future we seek madam's support for improving our PSU, especially PSU. And we hope we will get. We are thankful to Dr. Suren Verma sir for his kind acceptance of our invitation and delivering oration online. And also for his immense affection to KGMU and especially pediatric departments. He's always keen to come to KGMU and visit, do something for KGMU and pediatric departments. Professor Harish Chilani sir is known for his gentleness and his soft skin. So I have personal experience in 2005 and we went for MNCI training and that was for 9 days, sir. 7 days, 9 days. And everyone was praising about his soft skin. So you must have appreciated even during talk how soft and how gentle he is. Thank you, sir, for your acceptance and coming to this place. I convey my heartfelt thanks to faculties from other departments, Professor Arun Chaturvedi sir, Dr. Surkant sir, Dr. Sankhwa sir, Dr. Abhijit ma'am, Dr. Himanshu, Dr. Neeraj for coming and gracing to the department. I would like to mention my deep appreciation to our co-faculties, our staff, our residents for their support and hard work. Finally, I would like to thank everyone present in this hall, including the people from media. And people from pharma who has sponsored the events. So thank you, everyone. Thanks.
I thank everyone for sparing their precious time and joining us today in our Foundation Day ceremony. I request all of you to please join us for the lunch as well. It is going to be served at Kalam Center.
Yeah.
Okay, it is going to be served outside our seminar room. And once again, thank you all of you for gracing the occasion today.
Can I request the faculty to come at the back and residents आगे खड़े हो जाएं जितना फोटो में आ सके. Thank you. As many as can join, faculty and residents.